Good afternoon, everyone. So we start our session, our 105th session of e-NISCHIT. And this is our platform where we strengthen our collaboration between TB and HIV. So I welcome you all. Along with me on my panel is Dr. Jyoti from Share India and Mr. Rakesh, who help us to build this session. And we have Upasana ma'am, our mentor, along with us. So good afternoon to all the ART centers, and I welcome you all to this session. So today's session is going to be a very interesting case, and it is our case presenter today is Dr. P. Dharmapal, who is from a senior medical officer, General Hospital, Guntur, Andhra Pradesh, and they have always tremendously contributed to our e-NISCHIT, all the sessions, all the sessions that have been happening. So I thank you for sharing your case and being a case presenter today. And the case today is about HIV case, and the issues to be discussion is around ocular or eye TB or eye HIV. So this is going to be a very interesting, because as medical officers or as general practitioners, we have very limited knowledge about this subject, about ocular symptoms. So leave about diagnosis, it's not even easy to pick up a symptom of ocular disease. Like we can just make out the redness, but we will not know where we are heading towards, what we are looking at. Like we say, the eyes don't see what mind doesn't know. So for this thing, we are extremely fortunate today that we have such an eminent ophthalmologist as an expert today. And I welcome Dr. Jatinder Singh Bhalla sir, who is a consultant and academic in charge of Department of Ophthalmology, DDU Hospital, New Delhi. He is also the Secretary, Delhi Ophthalmological Society, and member scientific committee of All India Ophthalmological Society. I welcome you, sir. Thank you for joining us today, sir. And we are extremely fortunate to have you on board with us, sir. And sir is a very eminent ophthalmologist. And he has many feathers in his cap, such as awards such as DMA Eminent Teacher Awards 2022 and Trishan Singh Trophy for Best Clinical Talk. And sir's special interests are in cataract and glaucoma, with publication in peer-reviewed national and international journals for the same. And he has won multiple Best Papers Awards in 2017-18 and Best Paper Award in Asia Royal Trophy in 2018. So we are extremely grateful and privileged to have you on board, sir. So I'm sure we are going to benefit a lot. So thank you, sir. So first, we will start with the case presentation. So Mr. Dharmapal. So
Dr. Dharmapal.
Good afternoon, madam. Date of case presentation is 21st December 2023. And name of the patient and presenter is myself, Dr. P. Dharmapal, Senior Medical Officer, NRI Medical College, AP. Case code number they have given. And the name of the ART Center, NRI ART Center, Guntur, Andhra Pradesh. ART Center contact myself. And ART number is A19676. Age is 43 years of the patient. Gender is female. Weight is 50 kg now. But at this time of admission, she is only at 30 kgs. A case of Conundrum, that is confusion in problem that is difficult to solve. Because at the time, just I want to tell a brief history before that, going into that. The patient has got fever and vomitings and headache and other things. So local RMP has given some treatment, but the fever has not subsided. One day or two, once again rebound back. So they have given malaria treatment and other things. They are all negative. And afterwards, she developed some rash. Then the husband of the patient has taken her to All India Institute of Medical Sciences, where they have seen, and our ophthalmologist has given some treatment. And finally, she told it may be cytomegalovirus. But the fever has not subsided, and slowly a rash has developed. And then they referred to the All India Institute dermatologist, and he suspected HIV or syphilis and is tested. And where there is no facility for this treatment ART, so he referred to us. Then we have examined, and the weight and other things after careful examination. There are 4 symptoms of fever, loss of weight, cough, and night sweats, and loss of weight. All are these things there. So suspecting myself, it is a tuberculosis case also, has taken X-ray, and we referred it immediately to our sputum examination. But there in our institution, where the such physicians told it is CB0, that is cartridge-based nucleic acid amplification test is necessary, they told. So we referred the patient to Guntur district TB office where they tested and found it is CB0 is positive. So they referred back to our case to us, and then we have started as per the government of India schedule, according to the weight, 2 tablets, 4 FDC, 2 tablets per day as given, and slowly the temperature has come down, and the patient is suffering with vomiting also at that time. Our nodal officer, who is the postgraduate general medicine HOD and is a South India examiner also, he himself also has seen the case, and first he suggested me to let us first stop these vomitings and let us see. So we have started the treatment and I have given even the treatment, and of the ART, we stopped temporarily at the time. We have not started because the chest physician advised, because the patient is suffering with vomitings and other things. So it is better to stop, and afterwards you can stop after giving the tuberculosis treatment. After 2 weeks, we have started this ART treatment, tenoform, lamivudine, and dolutegravir. So the patient has now the loss of hepatitis has come down, and the patient is able to take some food and other things also very good. And the investigations also have done, and the serum creatinine is also 0.6 milligram dilution. Total bilirubin is within the limits, and AST is also within the limits, and the serum urea and also within the limits. White count is 5,300, and cells platelet count is 2.4, and lakhs of neutrophils 48%, lymphocytes 40%, eosinophils 0.8%, and monocytes 4.4%, and glucose is random, is within the limits. That is 79 milligrams per dilution, and the CB0 is also positive, and the X-ray of the chest is also mild hepatomegaly, ultrasonography, X-ray normal study is there, and ART regime is TLD. But the CPT we have given one OD, other midline is EVN tablets for RB. So the patient complains leg pains. So they suggested EVN 400 milligrams and UD-Liv for our liver problem, thinking that, and when we say eye drops and augmentin, 250 milligrams, and like ultraset for this one, and like that, TLD. Because we are giving the anti-tuberculosis treatment, so TD, another dose of dolutegravir also added for this patient. By after examining once again, we referred the ophthalmology department. They told it is better to send it to Shankar Netralaya. There they told it is better to send it to Prasad Eye Hospital. There they went to the Prasad Eye Hospital. There they told it is not looking like a cytomegalovirus, where previously they diagnosed. And once again, the patient is very anxious, and they have taken the patient to Arvinda's Eye Hospital. There they have diagnosed it vasculitis. So this is the case, and lot of investigations also. So they have seen, and vitrectomy also done by the Shankar Netralaya at Guntur only. So the occlusive vasculitis and uveitis is due to not taking treatment for HIV, because the history is in a very peculiar way. Her father and mother are both HIV positives. See, her husband is also positive. She is also positive. Her children, one male child and female child, both are negative. This is the history in short. So it is due to occlusive vasculitis of any allergy or phenomena of using any other drugs previously, because they have used so many other drugs, some with private practitioners. So they have suggested so many drugs for that case before coming to us. So this is the thing where our nodal officer examined the patient once again, 5 hours, taking 5 hours, and finally he concluded the case may be referred to Dr. Upasana Agarwal to give you, or she will call some expert of ophthalmology, and let us come to a conclusion. What is what? Whether it is due to prolonged HIV infection causing occlusive vasculitis, or the tuberculosis itself is causing occlusive vasculitis, or third one is itself cytomegalovirus itself, because ganciclovir or injections are given to the eye, and also oral treatment also, and so for this patient. So antiviral treatment is also given in these big institutions like Prasad Eye Hospital, Arvind Eye Hospital, and Shankar Netralaya. But by all these things, we are in a confusion. So just while we were discussing about this case, then just I told it is like a conundrum. That is a question mark. This side or that side, what to decide? So it is better than he himself suggested me, the nodal officer, it is better to refer the case to Upasana Agarwal ji. Then she will call some big band and we have more enlightenment about this case. So I think this is better since we forward the case to e-NISCHIT. This is the small story, what happened. But still, I got my phone down. Whether all these, the HIV and the cytomegalovirus is also common because some cases we are seeing here. So whether it is due to cytomegalovirus or due to because of prolonged vascular infections and other things because of HIV causing occlusive vasculitis or tuberculosis itself. Some people say, some of the ophthalmologists say it is not CMV. It is not CMV. Some say it is CMV. So we are in doubt. So it is better, sir. We request you kindly give some clarification whether it is prolonged infection of not eating any, having any treatment of antiviral treatment of saving. This is a nutshell, this one, sir.
Okay, so thank you, sir, for sharing this case with us. It is indeed very interesting, and it will be interesting even more when we get to hear the didactic. So this was a case is of a 43-year-old female who was HIV positive, and her parents were HIV positive. Her husband was HIV positive, but and children were not. But children were there, but they were not HIV positive. So she presented somewhere around June 2021 with symptoms of fever, headache, and diarrhea, and she was taking treatment from local practitioners and RMPs. And it was only when she got eye symptoms and her eyesight started diminishing, she went to a little higher tertiary centers like AIMS Hospital. And while she was getting treatment for all that, she got a rash, and there it was diagnosed as a HIV positive, and she was referred to NRI hospital for the ART treatment. So this was as this was happening, she was brought back to the center and with the symptoms rightly suspected and of pulmonary tuberculosis. Pulmonary tuberculosis diagnosis was made with the microbiological evidence in CBNAT, and I presume the reports are attached with the case summary. There was a X-ray also suggestive of pulmonary tuberculosis. So she was started on ATT, and her date of ART initiation was 4th August, and her date of ART initiation was 4th August, and then she was started on ATT on 2nd September. So she did not keep so well with the ATT. She had gastritis and she had symptoms for which she was periodically evaluated, and the ATT and ART had to be consequently withheld for some time. And then finally, she was continued on ATT and ART, and the ART which was given to her was TLD. But what was perplexing in this whole case was her eye symptoms, because she was diagnosed as CMV retinitis by AIMS Guntur, and she was given the treatment appropriate treatment for that, gang cyclovirs and 2 injection gang cyclovirs, and she was referred to a UVR specialist also, and for TAB she was given TAB Bhalla. So she was given all kinds of treatment and referred to UVR specialist. And she on 22nd December 21 she was also started on TAB valganciclovir, but still it was not with full conviction that because she did not respond so well, that what we were dealing with. That's the issue for discussion today, as I understand, that whether it was CMV retinitis or was it some kind of another occlusive vasculopathy, because considering the history she had the parents also HIV positive. So for that, we'll be now listening to the didactic by our experts here now. Yes, sir. So you can share them.
Okay. Thank you, everyone. Thank you, Dr. Upasana, Dr. Jyoti, and everyone, Team NISCHIT, for giving me this opportunity. It's indeed a very complicated case, but I'll try to present first the didactic and discuss the case scenario. So, yeah. So, as summarized very nicely by Dr. Dharmapal, The patient is a 43-year-old female whose both parents were HIV positive and they died of HIV. Husband is also HIV positive. Children are HIV negative. She was diagnosed to be having pulmonary TB by CBNAT on 4th August. Anti-TB treatment was started promptly on 4th August. ART treatment was started on 2nd September 21. I'm not sure about the CD4 counts earlier, but the CD4 counts as per available records, they started showing improvement, and subsequent to starting the ART treatment, CD4 counts on 6th January were above 100, 157, and 3rd March 22, they were more than 400, and on 12th August, they improved still further, that is more than 500. All these CD4 counts have significance as far as ophthalmological presentation is concerned. So as far as ophthalmology consultation and treatment is concerned, on 11th June 21, she was referred to AIMS Guntur, where she was diagnosed to be having cytomegalovirus retinitis, and anterior segment in both anterior segment had acute anterior uveitis. So I'll just for the briefly I'll mention what exactly is acute anterior uveitis. This is also a manifestation of HIV in the eye. What you get is behind the cornea, you get small inflammatory dots, which are known as keratotic precipitates, KPs. In the aqueous, you have some cells, and the iris becomes muddy, and iris sticks to the front of the lens, which is called anterior synechiae. So according to the records, the patient developed all these findings of acute anterior uveitis. So left eye, both eyes were diagnosed to be having CMV retinitis, and based on that diagnosis, she was given intravitreal injection of ganciclovir on same day, that is 11 June 21. She received intravitreal injection in left eye as well as right eye, and on 22nd 12/21, she was also started on tab valganciclovir for both eyes CMV retinitis. So the issues for discussion in the present case are, since the patient, after being referred to LV Prasad Institute, where they thought maybe this patient is not having CMV retinitis, but HIV occlusive vasculitis. So is the uveitis due to not taking treatment for ART for HIV, or is it due to TB granuloma? So that means whether the pathogenesis of this case was the retinitis was because of HIV, or which was untreated for by ART, or is it the TB is the cause, which is causing TB causes periphlebitis, not retinitis. Periphlebitis, that is the veins show veins on the retina show inflammation, sheathing, which may rupture, causing vitreous hemorrhage. TB may also cause anterior uveitis, which was present in this case, hence the confusion which has occurred. Or third, or the other possibilities is that the occlusive vasculitis is due to allergic phenomena to any of the drugs, like ganciclovir has been given intravitreally in both the eyes on 22nd June 21. 22nd, I think 12/21, or the valganciclovir, which are started orally. This is the microbiological report. So the diagnosis of CMV retinitis or HIV retinitis is based on the basis of not only the clinical picture, but also on demonstrating the presence of the antigen by PCR tests. So accordingly, aqueous and vitreous aspirates are taken. In this case, vitreous biopsy was done on February 22 to make a firm diagnosis whether it is due to mycobacterial tuberculosis, varicella zoster, herpes simplex, and cytomegalovirus. And incidentally, all these reports for PCR in vitreous sample turned out to be negative. So there was no objective demonstration of these opportunistic pathogen in the vitreous sample of the patient. This is the picture, which is almost a telltale picture. You will find this is not what we see in the retina. You find the picture is so hazy. Why it is hazy? Because the media which is in front of the retina, that is vitreous, is showing haze. That means vitritis is present. And if you find, these are the patches of retinitis. There is yellowish patch, there is and faintly I can see some hemorrhages also. Here also, this is the optic disc, this is the macula. Below the optic disc, you find some inflammatory patches, which is not as yellow as the top ones over the superior to the optic disc. Inferior to the disc, you find some inflammatory patches with the hemorrhages. So the main thing is presence of vitritis, presence of retinitis, and presence of hemorrhages. Mind you, CMV retinitis, if the diagnosis is made, it hardly has vitritis. If vitritis is present, either it is associated tuberculosis if the immunity of the patient is better. That means if CD4 count is better and there is TB associated with HIV, you will have vitritis along with the retinitis. Plain cytomegalovirus retinitis without tuberculosis will not have vitritis. Other important thing is if patient has other manifestation of HIV retinitis is known as acute retinal necrosis. Acute retinal necrosis, you may have significant vitritis along with the pictures of retinitis. So here the confusion starts from this picture. Because with the previous picture, I do not agree, somehow tend to agree with the diagnosis of CMV retinitis. Now let's come to the discharge summary, which was given from the ophthalmology unit. This was, I think, AIMS Guntur, where you find here that the patient has anterior uveitis, and if I see this, media shows hazy vitreous haze is there, and you find there is sheathing of the vessels, and disc is slightly pale. There is details are not clear. Retinal edema is there, and now they have given second dose of intravitreal ganciclovir in the left eye, and this is 12 January. So the first was done in June. And first was, I think, done June 21, and now the second dose of intravitreal ganciclovir has been given in left eye, because left eye was the worse eye compared to the right eye. So now we come that right eye has received just one intravitreal injection of ganciclovir, whereas left eye has achieved received 2 injections of intravitreal ganciclovir. And besides that, patient is already on, as I told you, this anti-tubercular therapy. So this is the fundus picture which the ophthalmologist has drawn at AIMS Mangalagiri. You will find that this shows there is vitritis grade 3, and you will find that the vitritis grade 3 is in the both eye. This is right eye, this is left eye, and you find there are these are retinitis. These red dots are hemorrhages. Again, in the other eye also, retinitis and hemorrhages along with vitritis is there, and they are also mentioning anterior chambers cells are positive. That means there is anterior uveitis and there is posteriorly retinitis with vitritis. So presence of vitritis again takes me away from the diagnosis of CMV retinitis. But incidentally, you will find that now they have started the patient on tablet ganciclovir also. And besides intravitreal ganciclovir, 2 injections left eye, 1 injection right eye, they have decided to start the patient on systemic ganciclovir. So here also, I think, yeah, please next. So now what exactly are we looking at? Is it HIV-related uveitis with CMV retinitis or acute retinal necrosis? Or is it ocular tuberculosis, or it is ocular toxoplasmosis? But there is no evidence of ocular toxoplasmosis. Neither the investigations point towards that direction, or the other important entities, immune-related uveitis. So based on the CD4 cell count, the ophthalmological manifestations also vary. If you have CD4 cell count less than 500, then the infection, opportunistic infection which the patient gets is herpes zoster ophthalmicus. Less than 200, they are likely to get either ocular tuberculosis or infection due to pneumocystis carinii. Less than 100, it is toxoplasma retinitis or retinal necrosis or cryptococcal choroidopathy, and less than 50 cells, it is cytomegalovirus retinitis. So what exactly is HIV retinopathy? This is the commonest ocular complication of the HIV infection. It is the retinal microvasculopathy, which is called as HIV retinopathy, and it occurs with CD4 cell count below 100 cells. And what you get on the retina is there are multiple cotton wool spots. The cotton wool spots are infarcts in the retina, small white patches with fluffy borders, and there are also small dot blot intraretinal hemorrhages. But mind you, these pictures can occur in any microvasculopathy which affects the retina, even in diabetic retinopathy or hypertensive retinopathy. And etiology is simple. It is HIV infection of the endothelium of the retinal microvasculature. Yes. Plus, there is deposition of the circulating immune complexes, and these presence which lead to retinopathy. But mind you, this HIV retinopathy is not noticed by the patient unless there is a fundus examination done by by ophthalmologist, because this retinopathy does not lead to any visual symptoms, as these retinopathy may have just cotton wool spots and hemorrhages, particularly in the peripheral part of the retina and not in the central macular portion. So CMV reaches the retina hematogenously, infects the retinal vascular endothelium, which spreads to the retinal cells. And if there is a impaired immunity, impaired CD4 count less than 100, less than 50, then it permits uncontrolled CMV replication. This is a picture of CMV retinitis. It occurs particularly with CD4 count less than 50. And what are the findings? You find there are retinal infiltrates. There is retinal vasculitis. This is the retinal vein, and you find this retinal vein is not as sharply demarcated uninvolved vein on the top of the optic disc as it is this one. There is irregular margins, there is frosted angiitis pattern, and you find these dot retinal hemorrhages are there. An important clinical feature, again, I stress again and again, is absence of significant vitreous inflammation. But mind you, our patient had significant vitreous inflammation. They have mentioned, Ames Mangalagiri had mentioned that vitritis grade 3. And in contrast, ocular tuberculosis and toxoplasmosis may have significant vitritis. So CMV retinitis occurs when CD4 count is less than 50, and it rarely occurs if CD4 count is more than 100 cells. And before the widespread use of highly active antiretroviral therapy, CMV retinitis was reported to the tune of 7 to 40% of this patient with AIDS, and this incidence has come down by 80% after starting HART. And CMV retinitis, it begins as a small white retinal infiltrates, which may resemble a large cotton wool spot. And the first lesion in CMV retinitis is a perivascular fluffy white lesion with many scattered hemorrhages. So you have perivascular fluffy, this is the vessel, you have perivascular fluffy white lesions with many scattered hemorrhages. And then there is central area of clearing in this hemorrhages, and then it develops into, progresses to atrophic retina. And once they disappear with the treatment, either intravitreal or the systemic treatment, this leaves behind atrophic retina and stippled retinal pigment epithelium. You may have small pigmentary changes in the retina. So diagnosis is based on the classical retinal findings and presence with diagnosis of HIV. Of course, objective complement of the diagnosis can be done by PCR analysis of the vitreous or aqueous aspirate, but differentiation from acute retinal necrosis of CMV retinitis is very vital, as the treatment of both is entirely different. So let us differentiate these three entities, because here is the confusion. CMV retinitis, acute retinal necrosis, or progressive outer retinal necrosis. You will find the immune status tells a lot about the condition. Acute retinal necrosis mostly occurs in healthy individuals, that is CD4 count is reasonably good, whereas progressive outer retinal necrosis or CMV retinitis occurs in immunosuppressed. Visual loss may be variable in CMV retinitis. Our patient had significant visual loss in the left eye, and because our patient also had involvement of the macula. And then other important thing is retinal involvement is full thickness in acute retinal necrosis and in progressive outer retinal necrosis. But in CMV retinitis, this full thickness involvement has a granular border, and the vitreous involvement is vitreous reaction has significant in acute retinal necrosis, but in progressive outer retinal necrosis and CMV retinitis, there is hardly any vitreous involvement or vitreous haze. So this is the picture of acute retinal haze. I showed you a fundus picture of CMV retinitis where you had perivascular fluffy exudate surrounding the vein along with the hemorrhages. Whereas acute retinal necrosis, you will find full thickness retinal involvement. It occurs mostly in the peripheral retina, but the progression of acute retinal necrosis is very rapid, unlike CMV retinitis, which progresses very slowly. And there is prominent, the main important thing which is fitting into our picture is prominent anterior chamber and vitreous inflammation. And if you see progressive outer retinal necrosis, which is unlikely in our case, because here what is there is that the inflammation is just minimal, just like in CMV retinitis, and there are very few hemorrhages in progressive outer retinal necrosis. So CMV retinitis, if I may tell you, it does not have a classical single type of picture in all the patients. It can be fulminant, where there is hemorrhagic necrosis with yellow cloudy retinal lesions. It can be granular. It is with little or no necrosis and little bit of hemorrhage. Perivascular, the classic frosted branch angiitis showing white lesions surrounding the retinal vessels. So this is the fulminant type. This is the granular type, fulminant type. I think it's a telltale picture. This is granular type, and this is frosted angiitis type. Surrounding the blood vessels, here you have the frosted. All these three are pictures of CMV retinitis. And these are the various zones. I won't go into the detail. If it is in the zone 1, that means it is going to affect your vision. But if it is in the periphery, zone 2 or zone 3, it may not affect the vision till it progresses to zone 1. So most of these patients are asymptomatic, right? But they may have mild floaters, flashes of light. But if it affects the central part of the retina, particularly the macula, you may have dark spot, which is called scotoma. Pain and photophobia are uncommon unless there is anterior uveitis in the form of, which I told you, synechiae, cells in the aqueous, etc. So how do we treat CMV retinitis? Like they have, based on the diagnosis, nothing wrong in the treatment. They have given oral valganciclovir starting in the December, and they gave intravitreal ganciclovir in both eyes, 2 injections in left eye and 1 injection in right eye. CMV retinitis, if it involves more than 25% of the retina, it can lead to retinal detachment, and then the visual prognosis becomes very grave. So to make a clinical, so what should we do in these patients of HIV? If you find that the CD4 count is falling, ophthalmological examination becomes mandatory, must. And when it should be done, it is not just one-time screening. Do the screening. If you don't find anything on the retina, don't leave the patient. You have to repeat the screening every 3 months, particularly when the CD4 count is less than 50, because now you are very likely to find CMV retinitis or HIV occlusive vasculitis. Now let's talk a bit about intraocular tuberculosis also, because this patient has been diagnosed to be having tuberculosis. There is X-ray picture which showed pulmonary tuberculosis, and CBNAT also showed evidence of tuberculosis. Now, tubercular retinitis, till now there is a dilemma whether it is due to hypersensitivity to tuberculoprotein antigen or it is infective. The current literature, current evidence suggests that this is particularly due to hypersensitivity to tubercular antigen. And it manifests not as a retinitis, it manifests as choroiditis with vitreous haze, vitritis. And when do we diagnose ocular tuberculosis? If there are clinical signs in the anterior chamber of uveitis, which are present in our case, there are vitreous haze is present, and ocular investigations, if we demonstrate AFB in either of the ocular fluid, aqueous or vitreous, PCR diagnosis or systemic investigations like X-ray evidence or PCR evidence or positive Montu reaction. So based on that, we label either as confirmed intraocular tuberculosis, probable intraocular tuberculosis, or possible intraocular tuberculosis. Confirmed is that is at least one clinical sign suggestive of intraocular tuberculosis, either anterior uveitis or the choroiditis or choroidal granuloma, and there is microbiological confirmation of mycobacterial tuberculosis from ocular fluids. And probable is when 1, 2, and 3 together, that is one clinical sign, one evidence on X-ray chest, or the microbiological confirmation, and third is documented exposure to tuberculosis. And probable is if of these three, either chest X-ray, the clinical sign is there, but chest X-ray not consistent with TB infection. But if TB infection, chest X-ray is there, but none of the either there is no documented exposure to TB, then it becomes a possible diagnosis. So confirmed probable, our patient has confirmed intraocular tuberculosis, although there is no microbiological confirmation of Mycobacterium tuberculosis, but there are clinical signs which are suggestive of tuberculosis anterior uveitis. Now, what happens if HIV and intraocular tuberculosis occur together? This leads to the confusion, as it has led in our current case. The ocular lesions mainly consists of choroiditis, serpiginous choroiditis, or choroidal granuloma. Choroidal involvement in patients with HIV infection may be non-reactive and not accompanied by sign of inflammation. So a confusion arises. If there is HIV along with intraocular tuberculosis, now the patient may have anterior uveitis, but the vitreous inflammation may be lacking. So we are not sure. But in our patient, there is no evidence of anterior uveitis may occur in HIV, anterior uveitis may occur in tuberculosis, but that is not the whole story. There is no choroiditis. So intraocular tuberculosis, at least the retinal finding is not there. So we can safely say that our patient is having only the occlusive vasculitis or CMV retinitis or acute retinal necrosis just due to HIV. So what should be done if your patient is having both HIV and tuberculosis? TB treatment is to be initiated first, followed by after 8 weeks by ART. Don't start ART first and TB treatment later. Now, this is one interesting case report which explains, I went through the literature, which explains what could have happened in our patient, because at various big ophthalmic centers, the confusion of CMV retinitis was so convincing, the diagnosis was so convincing that they had to start treatment with oral ganciclovir and intravitreal. If you give HRT, a heart treatment, then what can occur is the iris, that is inflammatory response uveitis and immune reconstitution inflammatory syndrome can occur as the CD4 cell count starts increasing. And how it is diagnosed? At least one focus of peripheral retinal necrosis with well-defined borders, rapid circumferential progression when antiviral therapy is not instituted, and occlusive vasculopathy with arthritis. So over time, there is rapid and circumferential progression of the peripheral lesion toward the posterior pole, as well as development of retinal necrosis with associated increase in the vitreous inflammation. So what do we do in these cases? We systemic antivirals like acyclovir or other systemic antivirals like oral valacyclovir can be started in these patients, and not ganciclovir. Even intravitreal ganciclovir may not be helpful because this is totally different. This is acute retinal necrosis which has started as immune reconstitution inflammatory syndrome after starting heart treatment, and not simply HIV occlusive vasculitis. So CMV retinitis may be asymptomatic, particularly with CD4 count less than 100 or 50. Heart has increased the survival rate. In some individuals, improvement of CD4 count with heart may cause immune reconstitution inflammatory syndrome. And what happens is, on starting heart, there is paradoxical worsening of the clinical manifestation or the appearance of new manifestation or increase in the vitreous haze. And what we do in these patients is totally different treatment. So again, come back to the issues which we started with. Is it due to uveitis due to not taking treatment for heart? No, the patient had promptly received, was started on ATT and heart. Is it due to TB granuloma causing uveitis? Unlikely. Is it due to occlusive vasculitis of any allergic phenomena or any other drugs? It is not allergic phenomena, but it is a sort of immune reconstitution inflammatory syndrome which started after the patient was started on the heart treatment. So what exactly is iris? it is a state of hyperinflammatory response that usually occurs in the first 6 months of starting treatment of HIV, and up to 25 to 30% of HIV patients who are on antiretroviral viral therapy develop iris. And what are the diagnostic criteria for this? Number one, of course, patient should be HIV positive. The patient should be receiving HART with decrease in either HIV-1 RNA level or increase in CD4 cell count from the baseline, which I showed you in the first slide, that the CD4 counts had started increasing our patient. There is increased inflammatory process which was there in our patient, and there is temporal association between iris and initiation of the HART. 2 months, yes, it was there. I think the treatment was started on September 21, and the intravitreal injection were given on December 21. And clinical course is not consistent with expected course of previously diagnosed ocular inflammation. So all patients with CMV retinitis should be treated for CMV before starting HART, which was done in our case because they thought the diagnosis is CMV retinitis. So they promptly started the patient on intravitreal ganciclovir and oral ganciclovir. And response to treatment, how do we see that CMV retinitis has controlled? See, the positive response to treatment is improvement in retinitis, vasculitis, and stepwise decrease in the inflammation in anterior chamber or vitreous. Start more aggressive anti-CMV treatment before and immediately starting HART to minimize exposure to CMV antigen. So what could have happened in our case is, if the patient indeed was of CMV retinitis, then the CMV retinitis should have been totally treated, and they should have done fluorescein angiography to see that CMV retinitis is totally resolved. Only then patient should have been started on HART treatment. Because if you start the HART treatment before the CMV retinitis is totally resolved, this CMV antigen may get released, and they say that there is a HIV-1 TAT protein, transactivator protein of HIV-1, which really leads to lot of inflammatory mechanism and leading to increase in the CMV retinitis like picture, or acute retinal necrosis, or increase in the vitreous haze. So this is what my hypothesis in the present case was, that patient was promptly started on the diagnosis which was made in our case, the vitreous haze. Was the vitreous haze there when the patient was started on HART treatment? That is one picture, because there was difference of opinion between LV Prasad Eye Institute, who felt that there is no CMV retinitis, and AIMS Mangalagiri, who felt that it was CMV retinitis. So based on the diagnosis, CMV retinitis treatment was started, and when the patient was next seen, there was a lot of vitreous haze, which goes against the diagnosis of CMV retinitis. So what could have happened was, there was development of immune reconstitution inflammatory syndrome, leading to the picture of acute retinal necrosis type, and as CD4 count started increasing, the vitreous haze also started increasing. So the ideal course of treatment at present, since the right eye is still a better eye with reasonably good vision, the patient can also be given a course of valacyclovir, and once that, and do fluorescein angiography to see that his retinitis picture is resolving. And then if ophthalmologists think it is okay, the patient can be given systemic steroids also.
Thank you, sir. Thank you. This was indeed a very complicated case, and thank you for making it so crystal clear to us. I really appreciate your way of teaching, sir. So I would like to ask Mr. Dharmapal, are your doubts cleared, or there's something you want to ask?
In the beginning, we tested viral loads also for this patient, because they have taken some drug outside. The CD4 may be vary, certain times giving certain drugs. So thinking that we have taken the viral loads from the beginning, the viral loads of HIV we have seen is only target not detected. That is below 1000 only viral loads. And the CD4 is also before that also. I have seen the reports recently. They are more than 500. 350, more than 500. CD4 is always high in this case from the beginning. After giving this ganciclovir and other drugs only, temporarily it is only 150. Once again it has gone up 450 like that, as for our reports. So that's
Because nowhere in the records I could find CD4 count less than 50. Only after starting heart in December 21, I have the reports, and they were either more than 150 or more than 200, and then later 680. So CD4 count less than 50 is one of the important diagnostic criteria for diagnosing CMV retinitis. So I tend not to agree with the diagnosis of CMV retinitis, because the clinical picture, although the retina picture was fitting in, but if you see the fundus picture which I showed you, there was a lot of haze. Unlike the textbook pictures which I showed you, the retina was absolutely clearly seen, both those portal spots and hemorrhages and perivascular fluffy things, all were very clearly seen, unlike in our patient, where the vitreous haze was so much that fundus details were hazily seen. So that really goes against the diagnosis of CM. Yes, I agree, it may be HIV occlusive vasculitis, and that may have been part of, I think, once the CD4 count started rising after giving heart treatment, it was because the vitreous haze never came down, whether at AIIMS Mangalagiri or at LV Prasad, everywhere they were mentioning vitreous haze. Vitreous haze should resolve with this thing, heart treatment. It should have resolved. If it is not resolving and it is increasing, then I tend to go more in favor of iris rather than HIV occlusive vasculitis per se.
Actually, this case was seen at Aravind Eye Hospital also, sir. Aravind Eye Hospital at Madurai. There also an occlusive vasculitis only.
Yeah.
What you are told is correct. It seems to be.
Exactly, sir. Exactly.
Now it was clear to me, sir.
Thank you. I try to simplify it, but since I hope I've been able to clarify some doubts, sir.
Hello, madam. Yes, madam. This is Jatinder Mukherjee. Actually, as you have rightly mentioned about the post-assessment, sir, it's a great presentation. But I want to know regarding the recommended treatment approach, because I'm a little bit confused. Is it a combination of systematic and intravitreal therapy, or is it systematic therapy alone?
See, if CMV retinitis, if there is a CMV retinitis, first you treat CMV retinitis with the intravitreal ganciclovir, oral valganciclovir, treat it completely. And only when you find that CMV retinitis has been treated, then start heart treatment. Don't start heart treatment if you have diagnosis of CMV retinitis, because then you are definitely going to have this immune reconstitution inflammatory syndrome. So that treatment should be completed. And then when you start heart treatment, you can be more aggressive, little more aggressive with this oral valganciclovir. Besides treatment, besides heart, you have to be. You don't have to let iris from happening, because it is really going to worsen the condition.
Got it, sir. Thank you. Thank you, sir.
And if patient is having tuberculosis also, so first anti-tubercular treatment, then treatment for CMV retinitis, and then treatment with heart. This should be the sequence in when treatment is given.
Yes, sir, we understand. Can we have the post-test poll answers for the benefit of the audience?
Yeah. So I'm now reading out the questions. The question 1 was, when is the CMV retinitis more likely to occur in patients with HIV infection? The correct answer is B. CD4 count less than 50 cells per microliter. The question number 2 is, how does CMV retinitis typically appears initially in retina? So the answer to the question is option B, perivascular fluffy white lesions. And the question 3 is, what is the recommended treatment approach for the patient with the peripheral non-sight-threatening CMV retinitis? The answer is systemic therapy alone, option B. I request our case expert to summarize the case and give us some takeaway messages.
Okay. So one important thing is, in any patients with the HIV, it should become a part of the protocol to have ophthalmic examination done. And depending on the slide where I showed that what are the opportunistic ocular manifestations we expect, depending on the CD4 cell count, the ocular manifestations will develop. Particularly important should be if the patient CD4 count is less than 100. That is the time not only one examination should be done, examination every 3 months is mandatory, so that we do not miss out lesion later on. And once patient develops any of these retinitis, HIV retinitis, whether it is acute retinal necrosis, progressive outer retinal necrosis, tuberculosis, cryptococcal infection, or TB choroiditis, or CMV retinitis, then the treatment of that particular entity has to be done properly. Regular follow-up is required, because these are sight-threatening condition, and we do not want a patient to be cured with heart treatment but having visual disability later on, because that will be a very unfortunate situation. But somehow what I feel is that since this is not a part of protocol, it is missed, and we feel happy that the patient has recovered to a great extent but has become visually disabled. So that is my humble plea to every one of you who is present here, that make this a part of your standard protocol. Involve ophthalmologist in the care of these HIV patients, and do the treatment as per the protocol suggested by your ophthalmologist.
Thank you, sir. Thank you so much, sir, for this excellent summer. So now it's the time we can close the session. So I thank Bhalla, sir, for making this section show. It's an excellent session for all of us. Thank you, sir. Now we'll be closing the session.
Yeah.
Thank you everyone for this opportunity, and thanks for having me here.
Yeah, thank you, sir. I thank our case expert for the excellent didactic. I thank our case expert who brings out some interesting cases for the discussion, for cross learning of all the participants. Thank you, Dr. Dharmapal. I thank Dr. Ananya who moderated the session. And I thank my whole team who is working behind the curtain. And I thank all our participants for their active participation. Thank you so much.
Thank you.